Hello and good afternoon. My name is Lisa.
I'm Susan.
And we're going to spend the next half hour or so telling you about our journey and preparation of going from a 32 to an 80 bay infusion center and how iQueue impacted our success. First, we have to tell you a little bit about Novant Health and Presbyterian Medical Center. And then we are going to go over, get my slides going. And then we're going to go over the pain points and why iQueue, the implementation process, our infusion expansion, the results of our implementation, and then we're going to share some best practices in our ongoing process improvements and goals. And then we'll have a brief Q&A, as Mallory had mentioned, where you can ask some questions. So a little bit about Novant Health and Presbyterian Medical Center. Presbyterian is a part of a large not-for-profit healthcare system in North Carolina, South Carolina, and Georgia. We're a 576-bed regional hospital located in uptown Charlotte, North Carolina, and we've been a cornerstone of Charlotte since 1903, when it started as a 20-bed hospital. In 1997, Forsyth Medical Hospital and Presbyterian Hospital merged to form what is known as Novant Health. And since that time, 9 hospitals have joined Novant Health and 5 hospitals have opened. And it seems like we have a new hospital every year. Presbyterian in particular has about 7,000 employees and more than 700 physicians on medical staff. You can see from this slide that Presbyterian Medical Center provides many specialized services we have over 7 centers of excellence, with cancer being one of them. In 2008, Presbyterian was honored with the prestigious Magnet designation, which we all know signifies high quality care and is the highest honor in nursing, with only 5% of hospitals nationwide earning this designation. The picture to the right of this slide is our beautiful 7-story cancer outpatient facility that also includes cardiovascular care, and that opened in October 2020. Every detail of this building was designed with the patient in mind, reflecting an environment of healing, which you can see in slides to follow, the beautiful interior space of this building.
PMC is one of the largest cancer centers here in the Carolinas, and we are an accredited cancer center by the Network on Commission for Cancer. We currently treat over 100 types of cancer. We have 32 cancer specialists here in our building with us and 12 specialty clinics. We offer surgical, medical, radiation oncology, integrative medicine, cellular therapy, genetic testing and counseling, nurse navigators, a palliative care program, and our fabulous cancer wellness center. For the purposes of this talk, we're going to talk about the 2 infusion centers that fall under PMC. And we refer to those, as you can see on this slide, the Charlotte Infusion Center, which is actually based in the hospital, which is where we used to be. And then our current infusion center is the Elizabeth Infusion Center. The Charlotte Center, as I said, is hospital-based. They currently operate using 17 chairs, 3 beds, and 1 injection chair. And that injection chair is just for lab draws and shots such as Xolair or Nucala. Depending on the volume of the patient schedule, there's typically 2 nurses, CNA, 1 scheduler, and a charge nurse. They are only open Monday through Friday, and they see just the non-oncology patients. We have a very large neurology practice that sends the majority of their patients to the Charlotte Infusion Center. So there's a lot of Ocrevus, Lemtrada, and Tysabri and Lemtrada infusions. We also see a lot of GI patients and pulmonary and primary care, a lot of blood transfusions, IVIG. They also perform monoclonal infusions for COVID positive patients. Very few of the patients that come to the Charlotte Center have a same-day appointment because it's in the hospital. Sometimes they are coming from a doctor's office. The pharmacy that their medications come from is located right on the unit with them, and the labs are sent to the central lab in the main hospital. The Elizabeth Infusion Center in our lovely building that you can see in this slide, that's one of our nurse huddles, and we actually have 4, and they all have a spectacular view. Currently, we are only using utilizing 43 of our chairs, 6 beds, and 1 injection chair. Sorry, I lost my place. All the patients that come to us are oncology and hematology patients, and about half of them have same-day appointments. So they're seeing a physician somewhere in this building or radiation oncology and coming to us in the same day. We have that small waiting area that we mentioned earlier to kind of, our goal is to move people through quickly, and that's what Lean Toss has helped us do. We have a vascular access area where the patients come and get their peripheral IV using ultrasound technology or a port access. And then they're moved on through into the infusion center. We do have a lab here in this building with us, and the pharmacy is here on the 7th floor with us as well. Pain points and why we chose iQuue. Previously, when we were across the street, as I mentioned, in the Charlotte Infusion Center, we were all together. We had developed a crosswalk or a spreadsheet, so to speak, with all of the drugs that we gave, and we scheduled infusions on the hour and all the injections on the half hour. And as you can imagine, that created a lot of bottlenecking. We would have anywhere from 6 to 8 patients all coming at 8 o'clock and then again at 9 o'clock. So that created bottleneck for the nurses and the pharmacy, because then we were notifying pharmacy that we were ready for 8 patients in a cluster, which caused a lot of backup. All our chairs were full, patients that were there for appointments, we weren't able to bring them back, which caused a delay in our waiting room as well. We weren't able to accommodate very many add-on patients, because if they had a visit with the doctor earlier in the day, they weren't able to come directly to us. We could usually accommodate them at the end of the day, which would require them to sit in our waiting room and wait, or go home and come back, which if they weren't feeling well really isn't ideal. Our nurses struggled to get lunch. We had blocked out a time from 11 to 12:30 for lunch, but it wasn't always practical for everyone to get to lunch at the same time. So that was a challenge as well. We did an assignment, myself and the other 2 CULs on our unit, and that typically took us about 1 to 2 hours, which was a challenge. So we knew moving into our new space, which was going to be 3 times the size, that we needed to make some type of a change, that we were going to have bigger problems on a larger scale if we didn't fix it then. One of the nurses that worked with us at the time had been working at UVA and had experience with iQuue, and was able to arrange for us to learn more about it. And about 1.5 years later, one of our service line executives had a personal experience with us in the infusion center and saw the delays in getting back and getting the treatment. And he was spearheaded the planning and the implementation of iQuue in the infusion centers based here in Charlotte. So our goal was to decrease the patient wait time and hopefully increase their satisfaction, and also twofold increase the satisfaction for our nurses here in the unit too. We wanted them to feel like they could step away and not feel like they were handing off too much to one of their coworkers, and iQue's really helped us work with that.
So here's the timeline of how we implemented iQuue in our infusion centers. In February of 2020, we identified who our stakeholders would be, and we began our planning. The stakeholders were service line leaders, clinical informatics, infusion scheduling, infusion nursing, referring providers, and their office staff. Then in April, our team reviewed the iQuue generated templates based on our historical data and began building those templates within Epic, which is our EMR system. Prior to iQuue, we had a crosswalk, which Susan mentioned, that listed when our infusions could be scheduled, but they were scheduled based on how long they were. So the morning part of our day was usually typically very busy. So we reworked our crosswalks to get them more accurate tracking of the cycle times, so that iQuue and Epic could build a more accurate template for us to rely on and depend on for learning our trends. We communicated our purpose and goals to our referring providers. Nurse and scheduler training began, and then we provided scripting to our nurses and schedulers so that patients that had been coming to us for weeks or months or years even, suddenly, if their appointment time was a little bit different than it had been before, the why behind that, hopefully to get them in and out of the infusion center in a more efficient way. Then in May, the schedulers spent the weekend moving existing appointments from the iQuue templates into the iQuue templates in preparation for our go live, which was actually June 1st of 2020. In August, we began planning for our new Elizabeth location that was scheduled to open in October. We used the predicted volumes of the oncology patients we were currently seeing, as well as the growth that we expected to have in the next 12 months. Then in September, the schedulers started moving appointments and scheduling future appointments into that Elizabeth scheduling template. And then October 26th of last year, the new Elizabeth building opened, and we continued to schedule with that template and schedule system. In April of 2021, we made some changes to our scheduling durations, tweaked our template based on our compliance data, which we're going to talk about some of the data tools that came out of iQuue.
As Lisa mentioned, we moved into our new building in October of 2020, and we then divided into the two separate centers. And our center was only going to grow because we had so much space, but initially we only utilized 49 of our total 80 chairs. And because the Charlotte Center was we were pulling away all of the oncology patients, they cut back and are only using 17 of their 32 chairs. So our initial templates that iQuue designed for us were based on the predicted volumes from the previous year. And as we continue to grow when we moved here, we have weekly meetings with iQuue, and any changes that we need, we were able to pretty much in real time. They worked with our IT department and were able to adjust the template to allow adding more longer infusions and more 1-hour visits where we saw that it was helping us more. And it was very flexible and really freed up our schedule, and we were able to spread things out further so we didn't have the bottlenecking.
So our early successes, we mentioned iQuue. We went live in June of 2020 with only having that Charlotte location open. And this slide is comparing iQue's impact using the data leading up to our launch and then post-launch. So the June 2019, the numbers here on the left was the June 2019 through May 2020, which was our historical data. And then the post data was June 2020 through May of 2021. And you can see our volumes were pretty steady. They were pretty consistent. But you can see over a 41% reduction in the average infusion wait time post iQuue implementation, as well as almost a 10% decrease in the average drug wait time. But what was impactful to us, especially, was that we had free chairs. So for those patients that were coming to their appointment, weren't waiting in a waiting room, or the physician's office that was calling to get an added on appointment for a patient, they could more easily get those appointments made, and patients weren't waiting in the waiting area for a freed up chair. This is a slide showing our infusion wait times. Again, the wait times went down across the board, even during our peak hours. Pre-iQuue patients had a consistent high wait time, you can see, throughout the day, with a slight peak at 8 a.m., which was when we opened the doors. So the patients that had to drive an hour to get here were sitting in our waiting room. And then that 12 o'clock hour, still waiting to get into the infusion center because of possible bottlenecking that was happening earlier in the day. And then the post iQuue, you can see the numbers are lower, significantly down from the pre-iQuue data. And we saw about half as many patients that were waiting more than 15 minutes before they got back to their chair as we did prior to iQuue. The drug wait time also went down across the board. We still had a spike midday around noon, which is consistent with what we were having before. I think there's still some amount of wait time that needs to happen for a drug to be delivered. So we would expect some gap in time, but we still have some internal workflows that we're changing and adopting in order to improve that as well. Our flow right now, once the patient comes and gets checked in with the scheduler, we send them over to the lab area for their IV to get placed or their port to be accessed. If they hadn't had labs drawn, we're drawing labs. Then they're brought back to their infusion chair. They're getting their measured height and weight. We're calculating a BSA. And then we're doing our 2-nurse calculation based on that day's body surface area. The nurse is performing a physical assessment and a toxicity assessment. And then we actually have the luxury of having nurse practitioners within our infusion department that may address any issues that have come up once the patients come to our infusion center. And that's probably a good reason why we're having still that 45 minutes before the drug is actually started with the patient. This graph actually shows that max chair occupancy. The pre-iQueue data, you can see we were maxed out. Here it is between 11 o'clock. Every infusion center has those bewitching hours, the 10 to 2, where you're slam full and sometimes run out of chairs. And that's what was happening with us that Susan was describing. Now, post iQueue, given the template that we had created, we never ran out of chairs and we always had availability, even during that highest peak in the day when we typically would have been completely full. So remember how Susan was saying that when we were using our own scheduling template, we had long infusions scheduled on the hour. So you can see these tall bar graphs are showing 5 patients coming in at 8 o'clock, 5 more at 9, 5 more at 10, so on and so forth. And then these smaller graphs in between are what our short visit appointments are on the half hour. You can see after we implemented iQueue, how that is more evenly smoothed out throughout the day so that nursing can keep up with the flow of patients coming in, pharmacy's able to mix the medication and deliver that in a more timely manner rather than getting all bogged down with multiple patients coming in at the same time.
So the innovations and best practices that we would like to share with you today, as we mentioned in the beginning, the small waiting room to keep the patients moving, we've really been able to, that hasn't been a problem. Our waiting room hasn't been full. Every 15 minutes have really spread things out for us, and our immunocompromised patients are not forced to all sit together in the same space. We've updated our crosswalk and made it a little bit simpler to follow. We've learned to be very adaptable and flexible, especially during COVID. In our old Charlotte Infusion Center that I mentioned that's still under operation, last year during COVID, they were doing monoclonal infusions for COVID positive patients, and depending on how many patients were scheduled, they had to adjust their schedule for upstairs in their regular infusion center. And some days they were only open in the afternoon, and iQueue was instrumental in helping us with that and changing that on a weekly basis as to what appointments were open and what was blocked and what was available. And that really helped the flow over there and allowed them to be flexible and accommodate those patients. It created a more spread out time for our nurses to go to lunch and to hand off to one another and cover for one another, which wasn't happening before. Something that's been very wonderful for myself and the CULs is we use the nurse allocation tool, which is how we do our assignment. We plug names in and iQueue runs it for you, and you have the ability to tweak it and shuffle things around, but it really gives you a great baseline to level load the assignment so nurses aren't overwhelmed. And that also gives us the availability when we have add-on calls for same-day appointments. We can see where there's gaps when the nurses have, if they're at lunch, when they have free time, this person should be going, or if we need to adjust an assignment, if one nurse is getting behind, she's had a reaction, or someone now needs TPA. It's a great tool for us to use to look back and see, okay, we can shuffle these patients around. It gives us a nice view to be able to do that. And we've used the schedule to help. If we don't have an available spot, we can see that we can jump up to another spot to accommodate fitting chemos, like last minute chemos, onto our schedules.
One of the things that was very exciting for me was all the data that was coming out of iQueue. There's a daily huddle that I use on a daily basis to just as a quick glance to the days and the future days volumes and the mix of patients that are coming based on their predicted chair time. So I could see if the schedule looked really heavy on Sunday, but it was lighter on Thursday, or light on Sunday, but busy on Thursday, I could adjust staffing and pull a nurse off Sunday's schedule to work Thursday when I knew that was a higher workload for that day. Using the daily huddle to steer the same day add-on appointments that Susan spoke of, or just shifting an appointment time. If it looked like we had a lot of patients that were coming in early in the morning because they had doctor's appointments, perhaps we could move an appointment from 9 o'clock to 1 o'clock when it was going to be a little bit lighter. The diagnostics reports that have come out are great for us just internally, but they're also really good tools to use during our leadership meetings. So we can inform them on how our chair utilization and our volumes are going in our department. We can trend wait times throughout the day or even day to day. We can observe our add-ons, number of add-ons and no-shows that we're having. Look at when patients are arriving early or how many patients are arriving early or late. Very, very useful and lots of data that we continue to look at. One of the other best practices that was really important to us before we went live with this system is obtaining provider and patient buy-in. Because sometimes when we would get before iQuue, you would get a provider office that would call and say, I have a patient that I need to add on or send over, and they would request a particular day or time. This system helps us make those decisions, and we needed to explain that to the providers so that they would understand if a patient typically came in at 10 o'clock on Tuesday, well, it may be better for that patient to come in Tuesday at 10:30, and they would get started quicker and they would go home earlier. The patient buy-in, we actually talked about that during previous appointments, and we also sent out a letter to our patients informing them of our new process and to be patient with us, but nurses and schedulers all receive that scripting on helping us stay on track with our templates so that we wouldn't sabotage it immediately when we went live with iQuue. So we still have work to be done, and we still have goals that we're trying to accomplish. We continue to track our data. We're looking at appointment groups. As Susan had mentioned, if we have to make an adjustment to a template, it's because we see that maybe we don't have enough 2-hour appointments available, but we have too many 3 to 4 hour appointments. We can make adjustments based on that data. Looking at the number of add-ons and cancellations and no-shows and why is that happening? Maybe we need to dig a little bit deeper to find out why those are happening day to day. Observing the chair wait times. Does it look like we're trending beyond the 15-minute wait time or the drug wait time of 45 minutes? And what processes need to happen to get us back on track? One thing that we're working towards that will help us with that drug wait time is scheduling a lab appointment earlier than 15 minutes ahead of the provider appointment so that the patient can have their labs drawn, see their physician, and before they leave the physician's office, they already know what their labs are, and they have the time to make adjustments to their treatment plan, rather than sending the patient to infusion and having them wait in our infusion chair or in our waiting room until those labs have resulted. So we're working on that. We continue to hardwire that daily management of using iQuue by our schedulers to actually use those empty spots to schedule patients in, especially with the same day add-ons. More daily management and the use of the iQuue diagnostics. The more we use it, the more familiar we get with it and the more information we can glean from it. So we're continuing to work on that. One internal thing that one of our goals is to build an acuity tool that would actually work in conjunction with iQuue, that would actually give a weight to a patient's infusion appointment, because we all know that it's not always about the numbers or the duration that they're there, but it's about the complexity of the patient and the complexity of the infusion. So that is something that we're working on internally. And then, our overall goal obviously is to have that patient chair ready. So once they arrive to infusion, we get them checked in, do all of our cross checks, sit them in their chair, and begin their infusion. So this is actually our last slide, and it's as Novant always, all of our things that we do, we try to tie back to our strategic imperatives. And I think iQuue fits in this very nicely with several of the imperatives that we have. The team resilience is kind of an understatement about nurses not being able to find time for lunch. They may run back and get 10 minutes of real quickly putting a snack in their mouth. Since we've gone live with iQuue, nurses truly are able to go to the break room and have 30 minutes of downtime and enjoy their lunch without feeling stressed to get back and take care of the patient. So that's been huge. The operational excellence, patient starting and finishing on time, will only improve the patient's satisfaction with their experience in infusion. Innovation and advanced analytics. This is a mathematical analytic program to place the patient in the right appointment at the right time. And then the industry growth. As we continue to grow, as cancer continues to grow, scheduling for an 80-bay infusion center requires us to work smart and efficient, and iQuue's helped us to do that. So that actually ends our presentation and our story at Novant Health. We're happy to take questions about Novant or iQuue, and then Mike can also help us answer any questions.
And Lisa, if I could add one thing
Yes.
that I think was really important and helpful for us was you mentioned the letter that we sent out to our patients. We started talking about it early on with the patients because I think by nature everyone's resistant to change. And we talked to the patients about it and explained to them it was going to be to their benefit. We knew it wasn't the times or the days that they always wanted, but it was going to make things move faster. And I think we started talking about that well in advance. So by the time we moved, they're all in that mindset, and it made it a little bit easier for our patients that we shared it with them early on.
Absolutely. Good point.